Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive.
Ugh.
We are jumping straight into the fire today.
We really are.
We're tackling a topic that, honestly, I think strikes more genuine fear into the hearts of nursing students and, let's be real, new grads and even seasoned nurses than almost anything else.
Oh, for sure.
We're looking at pediatric respiratory disorders.
It's the absolute high-stakes arena of pediatrics. It really is the great equalizer. You can have a nurse with 10 years of adult ICU experience. I mean, rock solid, seen it all. But you put a 6-month-old in respiratory distress in front of them, the heart rate in the room just goes up. It changes everything.
Because children are not just small adults, right? That's the cliche we hear on day one of nursing school.
Yeah.
But it's just so fundamentally true.
It is the truth of the field. And absolutely nowhere is that truth more critical, more, life and death than in the airway.
Right.
In pediatrics, the maxim is simple. Airway is king. If you lose the airway, you lose the child. And it happens fast. The margins for error are just razor thin.
Well, to keep you from hyperventilating, along with your future patients, we do have a very specific mission for this deep dive. We've combed through a massive stack of sources here.
A huge stack.
We're talking ATI pediatric nursing materials, the heavy-hitting Wolters-Kluwer textbooks, lecture slides, clinical charts, the works. And our goal is to boil this ocean.
We are going for the Pareto principle today, the 80-20 rule.
Exactly. We want to find the 20% of the content that is going to answer 80% of the exam questions you'll face, and vastly more importantly, handle 80% of the safety scenarios you will actually see at the bedside.
Yeah, we're bypassing the fluff. We are not here to memorize obscure statistics that nobody actually uses.
No.
We're going to focus on safety, pathophysiology, and that critical thinking, that NCLEX-style judgment that separates a rookie from a really safe practitioner.
So let's crack the code on this. We're dividing this deep dive into 3 distinct sections. Section A is the map, the big patterns that dictate everything in PEDS respiratory. Section B is the meat, the specific diseases, system by system. And then Section C is the cross-reference, where we're going to link it all together so you don't get tricked.
Sounds like a solid plan. Let's get to work.
Okay, Section A, the master 80-20 map. Before we even talk about asthma or croup or anything specific, you've identified some patterns in the source material. These are like the recurring themes that seem to dictate the rules of the game.
They really are. They're the foundational principles.
And the first one is catchy. You call it anatomy is destiny.
Or, as I like to call it, the case of the 4-millimeter straw.
Unpack that for me. This stat, it really blew my mind when I read the notes.
So if you look at the source images, specifically from the ATI and Wolters-Kluwer anatomy comparisons, there's this really stark visual. An adult trachea, the windpipe, is about 20 millimeters wide.
Okay, that's a pretty generous size, almost like a garden hose. You can move a lot of air through that.
It is a generous size, yeah. Now, look at an infant's trachea. It's approximately 4 millimeters wide. 4. That is roughly the width of a standard plastic drinking straw.
That is tiny. That is terrifyingly small.
It is. Now, here's the math that appears in almost every major pediatric respiratory text, and it's a favorite concept for exam writers because it involves physics, right? If you have 1 millimeter of swelling edema in that 20-millimeter adult trachea.
So 20 millimeters goes down to 19. No big deal.
Right. It's maybe a 5 to 20% reduction in the cross-sectional area. You might clear your throat, feel a little scratchy, you carry on with your day, it's an annoyance.
Right.
But if you take that infant with the 4-millimeter straw and you add 1 millimeter of edema all the way around,
You've practically closed it.
you have reduced the airway diameter by 50%.
Wow. 1 single millimeter equals a 50% loss of airway.
Yes. And here's the kicker. The resistance to airflow. So how hard that baby has to work to pull air in increases by a factor of 16.
16.
Yes.
16 times harder to breathe.
16 times the work. So A little bit of swelling in a baby is a catastrophic event compared to an adult. That is why we panic over a stuffy nose in an infant.
And speaking of stuffy noses, the sources mention that infants are preferential nose breathers. What does that actually mean in practice?
It means until about 4, maybe 6 weeks of age, they don't have the neurological reflex to automatically open their mouth and breathe if their nose is plugged.
They don't know how.
They're just hardwired to breathe through their nose. It's to facilitate breastfeeding, right? You latch on, you breathe through your nose. So if a newborn has a stuffy nose, whether it's from mucus or a condition like choanal atresia, they aren't just uncomfortable.
They're in actual distress.
They are in respiratory distress. They are, for all intents and purposes, suffocating.
That is a massive exam tip right there. If the question says newborn with copious nasal secretions, it is not a hygiene issue.
Not at all.
That's an airway issue.
Correct. Your nursing diagnosis isn't impaired comfort, it's ineffective airway clearance, and it's your #1 priority.
And there's one more anatomical nugget from the sources regarding the lungs themselves, the alveoli.
Ah, yeah, the little air sacs where all the magic happens. The gas exchange.
So adults have about 300 million of them.
A huge surface area, like a tennis court spread out inside your chest.
And infants.
They're born with only about 150 million, half.
So half the engine room.
Half the surface area means less room to trade oxygen for carbon dioxide. So when they get sick, when they have inflammation or fluid, they get hypoxic much, much faster. They just have less reserve. They run out of gas quicker. An adult can tread water for a while. An infant just sinks.
Okay, so pattern 1 is small airway, big danger. That is crystal clear. Let's move to pattern 2, the assessment hierarchy. How do we spot trouble before the code bell rings? Because looking at the sources, there seems to be a major trap here that catches a lot of students.
There is, and the sources all highlight a very specific progression of signs, and the trap is waiting for the wrong sign.
It's the wrong sign.
Cyanosis.
Turning blue.
Turning blue, yes.
But blue means lack of oxygen. Shouldn't that be what we're looking for?
If they're blue, you're late. I mean, you are profoundly late to the party.
Oh.
If they are blue, you are practically performing CPR. Cyanosis is a late, ominous, pre-terminal sign. If you wait for the baby to turn blue, you have failed the assessment.
Okay, so what is the first sign then? If I'm on top of my game, what am I actually seeing?
The sources all emphasize that the very first sign of respiratory distress and hypoxia is behavioral. It's the brain screaming, hey, I need more oxygen down here.
Behavioral, like crying.
Oh, not just crying, it's restlessness, irritability, agitation. Think about it. If I put a pillow over your face, what's the first thing you're going to do?
I'm going to thrash around. I'm going to get anxious. I'm going to fight.
Exactly. The baby can't use words. They can't tell you, I can't breathe. So they get restless, they get agitated, they get tachycardia, a fast heart rate, and tachypnea, fast breathing. Their body is compensating.
So, exam tip. The child is described as fussy and cannot be consoled, and is breathing fast. That is hypoxia until proven otherwise.
Bingo. Don't just assume they're hungry. Don't assume it's a wet diaper. Assume airway first. Always.
Okay, so after that initial restlessness, what are we looking at? The sources have great diagrams on retractions.
Right. Retractions are the muscles sucking in between the bones because the body is working so hard to pull air through that tiny swollen straw we talked about.
And there is a hierarchy here too, right? The location tells you how bad things are.
Yes, absolutely. It's a progression. It usually starts low on the body.
Okay.
You'll see subcostal, that's right below the ribs, or substernal, right below the sternum. As the distress gets worse, the recruitment of muscles moves up the body.
Moves up.
Yes. Next, you'll start to see intercostal retractions. That's when the muscles between the ribs get sucked in. Then, when things are really bad, you'll see suprasternal, that little notch above the sternum, and finally supraclavicular, which is above the collarbone.
So if I see a kid with muscles sucking in way up by their neck,
That is severe obstruction. The higher the retraction, generally speaking, the worse the struggle. If you see supraclavicular retractions, that child is using every single accessory muscle they have just to move a tiny bit of air. They are getting exhausted.
and there's a specific terrifying concept mentioned in the asthma sources that fits here. It's called the silent chest.
The silent danger. This is a classic NCLEX trap and honestly a real-life horror story.
Set the scene for me.
Okay, imagine you are listening to a child with a severe asthma attack. They're wheezing like a freight train. It's loud, it's scary. You can hear it from the doorway without a stethoscope.
Okay, I can picture that.
You give a breathing treatment, or maybe you don't have time, and suddenly The wheezing stops. The room goes quiet.
And the novice nurse thinks, oh, thank goodness they're better. The wheezing is gone.
And the expert nurse calls the rapid response team. Because wheezing is the sound of air moving through a tight tube. If the wheezing stops, but that child still looks like they're struggling, they're retracting, they're sitting bolt upright, maybe turning pale, it means they aren't moving enough air to even make a noise anymore.
That's total obstruction.
That is impending respiratory arrest. Silence is not always golden. In pediatric respiratory distress, silence can be deadly.
That's a chilling point.
No lie.
And it brings us perfectly to pattern 3. The noise dictates the location. I love this because it really simplifies things. The sound tells you where the problem is.
It's like a diagnostic map for your ears. There are 3 main sounds you absolutely need to master: stridor, wheezing, and crackles.
Okay, break them down for me. Let's start with stridor.
Stridor is a high-pitched inspiratory sound. It happens when they breathe in. It sounds like a seal barking or a high-pitched gasp.
And where is that coming from?
It comes from the upper airway, the neck area, the larynx or trachea. So think croup, think epiglottitis, or think a foreign body caught in the throat.
Okay, stridor equals upper. Neck issues. Got it. What about wheezing?
Wheezing is usually expiratory when they breathe out, and it's a musical sound, a high-pitched whistle. It comes from lower airway constriction. The bronchi and the bronchioles are squeezed tight.
So we should be thinking.
Think asthma, think bronchiolitis, or RSV.
Wheezing equals lower. The squeeze. Okay, last one. Crackles.
Crackles, sometimes you'll see them called rails. That sounds like Velcro being pulled apart or like rubbing hair between your fingers right next to your ear.
And what does that mean?
That is fluid in the alveoli, the very bottom of the lungs. So for crackles, you should immediately think pneumonia.
Crackles equals fluid deep down.
If you can just memorize that MAP stridor is up, wheeze is down in the squeeze, and crackles are fluid, you can answer half the scenario questions before you even read the vital signs.
That is the 80-20 right there.
Mhm.
Okay, we have our map. We know the anatomy is dangerous.
Mhm.
We know to look for restlessness first, not blueness. And we know what the noises mean.
Now we can apply it to the specific diseases.
Let's do it. Let's move to section B, the system-by-system lecture. We're going to cross-reference the ATI and Bolter's-Kluwer materials to give you the absolute need to know for each major condition.
Let's start at the top of the airway and work our way down.
Perfect. Up first, the sore throat spectrum, tonsillitis and pharyngitis.
Right. So clinically, this is simply inflammation of the lymph tissue, the tonsils, or the pharynx, which is the back of the throat.
Give me the one-liner on the patho. What's going on here?
It can be viral, and most of the time it is, which is self-limiting. You just need supportive care. But the big bad wolf here, the one we really care about, is GABI-HS.
Group A beta hemolytic streptococcus.
Or just strep throat to you and me. And the reason we care so much about strep isn't just because of the sore throat. The sources are very, very clear on this.
Why do we care so much then?
If you don't treat GABI-HS with antibiotics, it can trigger a delayed post-infectious autoimmune response in the body.
An autoimmune response from a sore throat.
Yes. The body creates antibodies to fight the strep bacteria, but those antibodies can then mistakenly attack the body's own tissues. Specifically, they can lead to rheumatic fever, which attacks and scars the heart valves, or acute glomerulonephritis, which damages and can shut down the kidneys.
So just to be clear, the antibiotics aren't just for the pain. They're to save the heart and the kidneys down the line.
Precisely. That's the why behind the prescription. You aren't just treating the throat. You're preventing potentially permanent organ damage. It's a huge public health concept.
That makes so much sense. Now, sometimes the tonsils are just chronically inflamed and they have to come out. Let's talk about the surgical fix, the tonsillectomy. This is huge on exams. There's a specific can't-miss complication.
Bleeding. Post-op hemorrhage. The tonsils are extremely vascular. When you cut them out, you leave a raw, open bed of tissue that has to scab over.
And when is the risk for that bleeding the highest?
There are 2 distinct windows you have to know. The first is obvious. It's the first 24 hours post-op immediate bleeding. That makes sense to everyone. But the second window is the trap. It's 7 to 10 days later.
Wait, 7 to 10 days after the surgery. Why the delay?
That's when the scabs, the eschar, start to slog off and fall off. If the tissue underneath isn't fully healed, or if the kid eats something rough and scrapes it, like a parquilla chip or a piece of toast, they can start bleeding again, sometimes heavily.
So what does the nurse look for? Because a 4-year-old isn't going to walk up to you and say, "Excuse me, I believe I am hemorrhaging from my tonsillar fossa."
No, they're not. And what's worse is they just swallow the blood. Blood tastes metallic and salty, and it just trickles down the back of their throat. So the number one Most frequent early sign of post-op bleeding is frequent swallowing.
Frequent swallow.
If you see a child after a tonsillectomy who is constantly gulping, swallowing, clearing their throat, you need to get a pen light and look in the back of that throat. They are very likely swallowing blood.
And eventually that blood is going to hit the stomach.
And they will vomit. It might be coffee ground emesis if it's old blood, or it could be frank, bright red blood. Which brings up a very practical exam tip and clinical rule. No red-colored fluids post-op.
No red popsicles, no cherry jello, no fruit punch.
Absolutely not, because if they vomit red fluid, you can't tell if it's Gatorade or blood. You want clear differentiation. It removes all ambiguity.
That makes total sense.
Yeah.
Now let's talk about the developmental angle here. You've got a toddler who just had major throat surgery. Their throat hurts like crazy. They don't want to drink.
Dehydration is the other massive risk. So really, pain management is actually dehydration management.
What do you mean by that?
If you don't adequately control their pain, they will refuse to drink. A toddler in pain will not swallow. So staying on top of the pain with round-the-clock Tylenol, acetaminophen, or whatever is ordered is absolutely key, so they will take those fluids. A dehydrated toddler is a toddler who ends up right back in the hospital on an IV.
Okay, that's a great connection. Let's move down the airway. Next up, Croup syndromes, specifically the classic one, acute Laryngotracheobronchitis, or LTB.
This is the classic. You will hear this sound in the grocery store in November, and you'll know exactly what it is.
The barking seal.
Exactly. It's almost always viral. Parainfluenza is a common culprit, and as the name says, it affects the larynx, the trachea, and the bronchi. Because of that swelling, remember our 4-millimeter straw, the subglottic area gets very tight.
And what's the typical presentation for Croup?
Usually a toddler, say 3 months to 3 years old, it's often a gradual onset, and it's classically worse at night. They might have had a little cold during the day, they go to bed, and they wake up at 2 a.m. with that characteristic barky, seal-like cough and inspiratory stridor.
That phrase, worse at night, is all over the source material.
It is. It's a key feature. So for the need-to-know interventions, if it's mild and that means no stridor when they're resting, only when they get upset and cry, the first-line treatment is cool mist.
Why cool mist? What's the science there?
It causes vasoconstriction. The cool, humidified air constricts the tiny blood vessels in the swollen tissue, which helps to reduce the edema just enough to open the airway a little. The old-school trick is to take the kid outside into the cool night air, or even just stand in front of an open freezer door. It often works surprisingly well.
Okay, but what if it's severe? What if they have stridor while they're just sitting there quietly watching TV?
Then we bring out the big guns. That's an indication for nebulized racemic epinephrine.
Epinephrine, like an EpiPen for allergies.
Similar concept, but it's a specific formulation that's nebulized and inhaled directly onto the vocal cords. It is a powerful, rapid-acting vasoconstrictor. It shrinks that swelling almost immediately, but and here's the major safety alert you have to know, it wears off very quickly.
You're talking about the rebound effect.
Exactly. The medication might wear off in about 2 hours, and the swelling can come right back, sometimes even worse than it was before.
So you can't just treat and street them.
Absolutely not. You cannot send a child home immediately after getting racemic epi. They have to be observed in the ER or admitted for at least 2 to 4 hours to ensure they don't rebound and lose their airway on the car ride home.
That is a critical safety point. Don't discharge the Croup kid immediately after the breathing treatment.
Correct. We also give corticosteroids, usually a single dose of dexamethasone, either oral or IM, to help with the inflammation long-term over the next few days.
Now, Croup has a scary and thankfully much rarer cousin, the true emergency, epiglottitis.
This is the nightmare scenario. Croup sounds worse than it looks. Epiglottitis looks worse than it sounds until it stops sounding like anything at all.
Give me the one-liner on the patho.
It's bacterial, almost always Haemophilus influenza type B, or Hib. The epiglottis, that little flap of cartilage that covers your windpipe when you swallow, gets infected and swells up like a giant, inflamed, cherry red cherry.
And if it swells too much, it just acts like a cork in a bottle.
It completely occludes the airway. Total obstruction. Game over. This is a can't miss, drop everything emergency.
So how do we spot this? The sources consistently list the 4 Ds.
Yes. Dysphonia, a muffled, quiet voice, often described as a hot potato voice, like they're trying to talk with a hot potato in their mouth.
Okay.
Dysphagia, they have severe pain on swallowing, so they can't swallow at all, which leads to the 3rd D, drooling. Because they can't swallow their own spit, it just runs out of their mouth. And the 4th D is distress. Respiratory
At
discharge.
the posture, there's a classic look, right?
The tripod position, you will never forget it if you see it. They are sitting bolt upright, hands on their knees or the bed, leaning forward and jetting their jaw out. They're physically trying to pull their airway open using gravity and muscle. They look terrified.
Okay, here is arguably the most important single rule in this entire deep dive.
Yeah.
If you suspect epiglottitis, there is one thing you must never, ever do.
Never, under any circumstances, put a tongue blade, a throat swab, or any kind of instrument into that child's mouth. Do not try to visualize the throat. Do not ask them to say, ah.
Why not? I mean, assessment is usually good, right? Getting a look is important.
Not here. The stimulation of the gag reflex, or even just touching that inflamed epiglottis, can trigger a complete laryngospasm. The airway will slam shut, and because it's so swollen and edematous, you cannot bag mask ventilate them. You cannot easily intubate them. You have just lost the airway completely.
So if the exam question asks, the nurse suspects epiglottitis, what is the priority action?
The answer is almost always something like, do nothing to upset the child, or keep the child calm and prepare for emergency airway management. You do not inspect the throat. You keep them with their parents. You let them stay in their position of comfort. You call for help, anesthesia, and ENT, and you get them to the operating room for a controlled intubation.
And thankfully, we see less of this now than we used to.
Yes, this is one of the great victories of modern medicine. The hive vaccine, which starts at 2 months, has made bacterial epiglottitis incredibly rare in vaccinated populations. But you still see it, so you have to know it.
Developmentally, if you have a child in that tripod position, drooling, looking toxic,
you do not leave their side. Your job is to be the calm in the storm. You keep the parents there to keep the child calm. Crying makes the swelling and the obstruction worse. Your entire job is to be the Zen master until that airway is secure.
Okay, wow. Moving down from the throat into the chest. Bronchiolitis, aka RSV.
Respiratory syncytial virus. This is the scourge of every pediatric unit in the winter.
So what's actually happening inside the lungs here? This is a lower airway problem.
Right. This attacks the bronchioles, the tiniest little airways that lead to the alveoli. It causes inflammation, sure, but the main problem is that it causes the production of tons and tons of thick, sticky mucus. And it also causes sloughing of the dead epithelial cells from the airway lining.
So the airways are getting clogged with all this debris.
Exactly. It's like trying to breathe through a straw filled with rubber cement. And because babies have those tiny airways to begin with, they get air trapping. They can get air in past the mucus, but they can't get it back out. The lungs get hyperinflated and they have to work incredibly hard to breathe.
And who gets this the worst?
It's most severe in infants under 2 years of age, and especially in premature babies or those with underlying heart or lung disease.
So what is the need to know assessment? What does an RSV baby look like?
It's a wet, messy disease. First, rhinorrhea, a runny nose like you wouldn't believe, just copious, thick nasal secretions. Then you'll hear wheezing, a horrible hacking cough. And because they're working so hard, you'll see tachypnea and retractions.
And the sources all mention a specific risk related to feeding.
Yes, this is critical. Remember, infants are nose breathers, and they have to coordinate that complex suck-swallow-breathe pattern. If they're tachypneic breathing 60, 70, even 80 times a minute, and their nose is completely full of snot, they cannot safely eat.
They'll aspirate.
They'll aspirate, or they'll just get too tired and give up. So dehydration is a major, major secondary issue.
So what's the #1 priority intervention then?
Suction.
The snot sucker.
The nasopharyngeal suctioning. Before they eat, before they sleep, and anytime they look like they're in distress, you have to clear the path for air. It's often more effective than oxygen.
What about medications? Do we give antibiotics?
No. It's a virus. Antibiotics will do absolutely nothing. It's a common mistake, but it's incorrect.
Okay, what about bronchodilators? Like albuterol. We use that for wheezing in asthma.
This is controversial. The official sources and guidelines say it's not generally recommended, but you will sometimes see a trial dose given. The reason it's often ineffective is that the problem in RSV isn't primarily bronchoconstriction, a muscle spasm. The problem is obstruction from mucus and debris. So relaxing the muscle doesn't clear the mucus plug.
So it's really just supportive care. Oxygen, suction, and hydration.
That's the core of it. And isolation. RSV is incredibly contagious and spreads like wildfire on a pediatric floor. It requires contact and droplet precautions. That means gown, gloves, and a mask.
And nice to know. There is a way to prevent this in high-risk kids, right?
Yes, there's a medication called palivizumab, brand name Synagis, or the newer nirsevimab. These are monoclonal antibodies. They are given as monthly injections to preemies or babies with significant heart or lung disease during RSV season to give them passive immunity and prevent severe infection. It's not a vaccine in the traditional sense, but it's very effective.
Okay, let's move on to pneumonia.
Right. The definition here is inflammation of the lung parenchyma. Basically, the alveoli, those little air sacs, fill up with fluid or pus.
And this can be viral or bacterial.
It can be either, and the presentation can vary. In younger kids, it's often viral and follows a cold. In older kids and teens, we start to see more bacterial causes like mycoplasma, the walking pneumonia, or strep pneumo.
What's the classic assessment for pneumonia?
A high fever, a cough, which can be productive with colored sputum or just dry and hacking. Tachypnea is a big one, sometimes chest pain, especially with breathing. And remember our sound map from before? Crackles, or what we call dullness on percussion. Tapping on the chest over the affected area will sound dull because you're tapping over fluid, not air.
And what are the key interventions?
It depends on the severity. Oxygen for hypoxemia, for sure. Antibiotics if it's bacterial. Antipyretics like Tylenol for the fever. And fluids to thin the secretions. And positioning is also important.
The sources mention splinting. What is that?
If a child has chest pain from the coughing or pleural irritation, having them hug a pillow or a stuffed animal tightly against their chest when they cough, that's splinting. It helps to brace the chest wall and manage the pain so they can take a deeper, more effective cough to clear secretions.
Okay, that's a great practical tip. Let's talk about a huge chronic one, asthma.
The most common chronic disease of childhood. You will see this everywhere.
The sources define it as a chronic inflammatory disorder with reversible airway obstruction.
And that word reversible is the absolute key. It sets it apart from things like CF or anatomical defects. It comes and goes. The airway can be completely normal between attacks, but it's always hyper-responsive to triggers.
And the patho involves three things. The asthma triad.
Yes, you have to know these three. Inflammation. The airway lining is always chronically swollen and angry. You have mucus production thick, tenacious mucus. And you have bronchoconstriction. The smooth muscle wrapped around the airways spasms and squeezes them shut.
So how do we treat this three-headed monster? The sources outline a tiered system of medications.
This is the absolute bread and butter of asthma management. You have rescue meds and you have maintenance meds, and you must know the difference. It's a huge safety issue.
Let's start with the rescue meds.
These are the short-acting beta agonists, the SABAs. Albuterol is the prototype. This is your in-case-of-fire, break-glass medication. It works within minutes to relax that squeezed, smooth muscle and open the airway.
What are the side effects parents should know about?
It revs you up. It can cause tachycardia, jitters, a feeling of anxiety, even hyperactivity in some kids. Parents need to know this is a normal and expected side effect. Otherwise, they get scared and might not give a medication that their child desperately needs.
Okay. And the maintenance meds, the controllers.
These are the meds that prevent the fire from starting in the first place. They treat the underlying inflammation. The cornerstone of this is inhaled corticosteroids, like fluticasone, or you might see leukotriene modifiers, like Montelukast brand name Singulair.
And what's the most important teaching point for those inhaled steroids?
Rinse the mouth out with water after every single use. If the steroid medication sits on the tongue and oral mucosa, it can suppress the normal flora and lead to thrush a painful oral fungal yeast infection.
So just to be crystal clear, do you ever use a controller medication for an acute attack?
Never. Absolutely not. It's a common and dangerous mistake. It won't work fast enough. If a kid is gasping for air, you give them albuterol, not fluticasone.
Let's talk about the equipment. Spacers. The sources all have pictures of a metered dose inhaler, an MDI, with a spacer chamber attached. Why is that so important?
A spacer is non-negotiable for kids. Honestly, it should be for most adults too. Without it, the medicine, which comes out of the MDI at about 60 miles per hour, just hits the back of the tongue and gets swallowed.
So it doesn't even get to the lungs.
Barely. With a spacer, it holds the aerosolized mist in the chamber, allowing the child to take a slow, deep breath and inhale it deep down into the small airways where it needs to go. It increases the drug delivery efficiency by a huge margin.
In the peak flow meter. This is like a traffic light system for their breathing.
It is. It's an objective measure of how open their airways are. Green zone is 80 to 100% of their personal best number. They're good to go.
Okay.
Yellow zone is 50 to 79%. This is a caution sign. The airway is tightening. The asthma action plan will say to use the rescue inhaler, albuterol.
And red zone.
That's below 50% of their personal best. This is a medical alert. Danger. The plan will say to use the rescue inhaler immediately and call the doctor or go straight to the emergency department.
What about status asthmaticus? This sounds like a Harry Potter spell, but it's really bad.
It means the asthma attack isn't breaking. It's refractory to treatment. They've had multiple doses of albuterol and they are still in severe distress. This is a medical emergency that requires IV magnesium sulfate to help relax that smooth muscle, as well as continuous nebulizers and high-dose systemic steroids.
Developmentally, how does chronic asthma impact a kid's life?
It has a huge impact. It's a leading cause of school absenteeism. It can lead to exclusion from sports if it's not well managed, though with a good plan, they absolutely should play sports, just pre-medicate before exercise. And there's a concern about growth. Long-term, high-dose systemic steroid use can slow bone growth, so we have to monitor their height carefully.
Okay, we have to shift gears to a genetic heavyweight. Cystic fibrosis, or CF.
This is a multi-system disorder. It's so much more than just the lungs.
And it's autosomal recessive.
Meaning both parents must be carriers of the faulty gene. And if they are, there's a 25% chance with each and every pregnancy that the child will have CF.
The patho is fascinating. It's a defect in a chloride channel.
Right, the CFTR protein. In very simple terms, the cells can't move chloride, which is a component of salt, and by extension water, properly across the cell membrane. The result is that mucus secretions everywhere, in the lungs, the pancreas, the gut, the reproductive tract, become incredibly thick, sticky, and dehydrated. It's like trying to move cement.
How is it diagnosed?
The gold standard is the sweat chloride test. Because the sweat glands can't reabsorb the chloride, their sweat is incredibly salty. Parents will often be the first to notice, saying, "When I kiss my baby, he tastes like salt."
A sweat chloride level greater than 60 millieql is diagnostic for CF.
Let's break down the management of this. It's intense. Let's start with the respiratory side. They need aggressive pulmonary toilet, a daily routine to clean out the lungs. The cornerstone of this is chest physiotherapy, or CPT. This can be done with cupped hands, percussing on the chest wall, or more commonly now with a high-frequency chest wall oscillation vest.
The shaker vest.
The shaker vest. It vibrates at a high frequency to loosen that thick mucus from the airway walls.
And how often do they have to do this?
Every single day. Often twice a day for 20 to 30 minutes each time. When they get sick, it can be up to 4 times a day. It's a huge burden of care.
And the sequence of medications and treatments matters here, doesn't it?
Critically. You give the bronchodilator, like albuterol, first to open up the airways as much as possible. Then you might give an inhaled mucolytic, like Dornose alpha, which is an enzyme that acts like molecular scissors to chop up the thick mucus. Then you do the CPT to shake it all loose. And finally, you have them do huff coughing to get it up and out.
Wow. Now, the GI side, this is where the exams love to test because it's so unique to CF.
The same thick mucus that clogs the lungs also clogs the tiny ducts of the pancreas. So the digestive enzymes that the pancreas makes, the ones needed to break down fat, protein, and carbs, can't get to the food in the intestine.
So the child eats, but they can't digest or absorb the nutrients, resulting in
2 things. First, steatorrhea, which is fatty, frothy, foul-smelling, floating stools. And second, failure to thrive. They are literally starving despite having a ravenous appetite.
So the key intervention is replacing those missing enzymes.
Yes. They must take pancreatic enzymes in capsule form with every single meal and every single snack.
Every single snack.
Yeah.
They eat 1 cracker.
If they eat 1 cracker, they take enzymes. If they have a glass of milk, they take enzymes. Otherwise, they don't absorb the nutrients. For babies and young children, you can open the capsule and sprinkle the little beads on a non-alkaline food like applesauce, but you must teach parents not to let them chew the beads because they are enteric-coated and can burn the mouth.
On the diet itself, usually for chronic diseases, we think low fat, low salt.
CF is the complete opposite. They need a high-calorie, high-protein, unrestricted fat diet, and they need extra salt. Because they lose so much salt in their sweat, they are at constant risk for hyponatremia, especially when it's hot or they have a fever.
That is such a crucial counterintuitive fact that makes for a perfect exam question.
It really does. Also, they need supplemental fat-soluble vitamins A, D, E, and K. Since they don't absorb fat well, they can't absorb these vitamins from food, so they need to take special water-soluble forms of them to prevent deficiencies.
One last specific need to know on CF. What is the earliest possible sign in a newborn?
Meconium ileus. This is when the baby doesn't pass that first sticky black stool, the meconium, within the first 24 to 48 hours. It's because the meconium is even thicker and stickier than usual and it gets stuck, causing an intestinal blockage. About 10 to 20% of babies with CF will present with this at birth.
That is heavy stuff. Let's do a quick hit on a couple of acute issues. First, foreign body aspiration.
Toddlers put everything in their mouths. It's a developmental stage. If they inhale something small like a peanut, a piece of a hot dog, or a toy part, where does it most likely go?
It goes to the right bronchus.
Correct. The anatomy dictates this. The right main stem bronchus is shorter, wider, and straighter than the left. So gravity and momentum favor the right side. So you'll often hear diminished breath sounds or a localized wheeze on the right side specifically.
And epistaxis, the simple nosebleed.
A classic playground injury. And the old advice from our grandparents was, tilt your head back.
Which is wrong.
Very wrong and potentially dangerous. That just makes all the blood run down the back of their throat, which can cause nausea, vomiting, and a risk for aspiration. The correct position is to have them sit up and lean forward.
Lean forward.
Yes, and pinch the soft, fleshy part of the nose, not the bony bridge, but the soft cartilage below it, and hold continuous pressure for 10 solid minutes. No peeking.
Okay, we have covered the systems. This is great. Let's move to section C. Cross-linking and comparisons. This is where we synthesize and make sure we don't get these conditions confused.
Let's compare croup versus epiglottitis again, just to hammer it home, because they both present with stridor, and confusing them is dangerous.
Okay, lay it out for me. Croup.
Croup? It has that loud barking cough. The patient sounds way worse than they actually look. The treatment is supportive with cool mist and, if needed, racemic epi and steroids.
Yeah, epiglottitis.
Epiglottitis. There is no cough. The room is quiet. The patient looks toxic. They're in the tripod position. They're drooling. The treatment is protecting the airway and IV antibiotics.
Perfect. Next pair. Asthma versus bronchiolitis. Both have wheezing.
They do. But asthma is usually related to an allergic or chronic trigger. The cough is often dry. And the treatment is with bronchodilators and steroids. It responds well to albuterol.
And bronchiolitis.
Bronchiolitis is viral and seasonal. You see it in the winter. It's a very wet disease with tons of secretions. And the treatment is primarily supportive, suction and hydration. It often doesn't respond well to albuterol.
And finally, let's compare the logic of the tent versus the vest.
Right. We use humidity, like a mist tent or a cool mist humidifier for upper airway swelling, like in croup. The goal is to soothe the inflamed mucosa.
Okay.
We use percussion, the vest, or manual CPT for lower airway mucus plugging, like in CF or pneumonia. The goal is to physically shake the mucus loose so it can be coughed out. You would generally not do CTT on a kid with croup. It would just agitate them and make the stridor much worse.
That is excellent clinical judgment right there.
One last link. Development. We've touched on it throughout, but it's important to remember that any hospitalization for a serious respiratory illness can cause regression in kids.
You mean the toddler who is perfectly potty trained suddenly starts wetting the bed again?
Totally normal. It's a stress response. Don't shame them and support the parents in understanding that. And for the teenager with CF or asthma, the developmental task is all about identity and peer acceptance. It's all about compliance and body image. They don't want to be different. They don't want to take pills or do an inhaler in front of their friends. That's where the nurse has to become a negotiator and an educator, not just a task doer.
Incredible. We have mapped the airway, we've dissected the diseases, and we've linked it all back to safety and development.
We've covered the 4-millimeter straw, the frequent swallowing after tonsillectomy, the danger of the silent chest, and the importance of salty sweat.
So as we wrap up this incredible deep dive, what is the one provocative thought you want to leave our listeners with to mull over?
It's the concept of work of breathing versus oxygen saturation.
Okay.
New nurses, and even experienced ones, can get fixated on the monitor. They look up and say, oh, his O2 sat is 95%, he's fine.
Right, the number looks good.
But you have to look at the child. Is he retracting? Is he using his neck muscles? Is he grunting with every breath? Is his respiratory rate 60 times a minute? A child has a tremendous physiological reserve. They can maintain a normal O2 sat by, working incredibly hard, right up until the moment they run out of energy.
And bed?
Then they crash. They don't drift down gently. They fall off a physiological cliff. They go from compensating to coding in a matter of minutes.
So treat the patient, not the monitor.
Exactly. If the work of breathing is high, that child is in danger, no matter what the number on the pulse oximeter says. Your assessment of their work is a better predictor of their stability than that number is.
That is a powerful and essential thought. Thank you for that deep dive. Listeners, go find that 4-millimeter straw and protect it. We'll see you on the next one.
Stay safe out there.